You're listening to Medscape's In Discussion series on multiple myeloma, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Joseph Mikhael, Chief Medical Officer of the International Myeloma Foundation and Professor at TGen City of Hope Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, my name is Dr. Joseph Mikhael, and welcome to Medscape In Discussion Multiple Myeloma. Today, we're talking about screening for early stage multiple myeloma. And I think this is actually a particularly important topic. For so many years, we only defined myeloma as being present when patients had organ damage, the classic CRAB criteria: calcium elevation, renal insufficiency, anemia, and bone disease. But over the last several years, we've been changing that definition to try and catch the disease earlier. Sometimes I give the analogy because I'm a runner. If I'm running towards a cliff, hopefully someone will catch me before I fall off the cliff and run into trouble. And that's kind of what we've done with myeloma. We only used to define myeloma after someone had fallen off, but we want to catch patients earlier and earlier, not too early because maybe they'll never make it to the cliff, but early enough. And understanding that sweet spot space is really the focus of our discussion today, and when we should do so and how we should do so. And my guest today is a world-known myeloma expert and also a very dear friend, Dr. Irene Ghobrial. Dr. Ghobrial is a professor at Harvard Medical School and is a hematologist at Dana-Farber, and she has dedicated much of her work and career to understanding this field. So welcome, Irene. It is always good to be with you.
Thank you, Joe. It's a pleasure to be with you.
So Irene, let me just ask you right off the start, of all the areas of myeloma, and we have so much going on now with new treatments and new approaches, what drew you to this area of understanding earlier disease and maybe even screening for myeloma? What was the impetus to draw you to that?
Yeah, and I have to say that it started with actually the grandfather of myeloma, Bob Kyle. I trained at Mayo Clinic almost 17 years ago now. And Bob Kyle was the first one to coin the name monoclonal gammopathy of undetermined significance. And it was because him and Jan Waldenstrom described it. They saw those asymptomatic people. And I think Jan wanted to call it benign gammopathy, but Bob Kyle said, well, they may actually develop myeloma. Let's track this. Let's look what's going on in those people and see if they will develop myeloma. And he wanted to call it undetermined significance because of the potential of developing cancer. And he had this amazing insight of 50 years in advance to truly understand a precursor condition, to define it early, and to track it for 50 years. So we're very lucky that we have so much information about a precursor condition just because Bob Kyle saw it 50 years ago. Now, going back to why would I do that? I've had my share of seeing many people with multiple myeloma, and it hurts sometimes to see people coming in with symptoms, with fractures or anemia, and then we start the workup and the diagnosis, and then we tell them, oh, you do have multiple myeloma, let me treat you. And if you ask those people, well, if I had diagnosed it a few years ago, would you have wanted to know that? If I diagnosed you 4 or 5 years ago when you didn't have the fracture or the anemia or the kidney failure and you didn't need dialysis, would that make a difference for you? And I can tell you 100% of people would say yes. And if you think about it, every single patient with multiple myeloma who comes today to see us must have had an earlier precursor condition of MGUS or smoldering myeloma. And we did not diagnose it because we don't go looking for it. So shame on us if we can do something about that and change that. If we can change the perspective of let's diagnose it early when it's still asymptomatic, and let's intervene early before the fracture and the anemia and the renal failure, wouldn't that make a huge difference, not only for their survival, but for the quality of life and for their own idea of, I am not suddenly being diagnosed with something and it's falling apart. Let me actually plan for it. Let me be proactive about it.
Wow, that's fantastic, Irene. I love how your passion comes through with this and your history of where we've been in myeloma and where we're going. So thank you for that insight. I have to say, as we start to dive into this conversation, I thought of you this week when I saw a patient in clinic. So I saw a patient in clinic who is relatively recently diagnosed with multiple myeloma, and her community oncologist wanted my opinion about whether or not we should take her to stem cell transplant. She was accompanied by her sister. And her sister said something very fascinating to me. She said, we know it was many years ago, but our father had something in his blood. We never knew what it was before he passed away. And I went and got tested, and I have this thing called MGUS. Do you know what that is, doctor? And of course I said, well, yes, like yourself, I've been very close to Dr. Mikhael when I was at Mayo Clinic. And it got me thinking, because she looked at me and said, well, we have another sister. Should she be screened for myeloma? And I know that may be one extreme example to have two siblings with this, but I think it raises the issue and shines light on a lot of the great work that you have done recently on trying to understand if everyone who has myeloma had previously MGUS, when should we start looking for it, especially because we know that MGUS is so common. We think of myeloma as being a rare cancer, maybe 1% to 2% of all cancers. But I could argue that it's maybe one of the most common cancers in the world, because 5% of people over the age of 40, if we look for it, we find it. Just like you mentioned earlier, if you don't, the old adage, if you don't take a temperature, the patient won't have a fever. So if we don't look for something, we're not going to find it. So let's dive in. Irene, I've heard you talk about this topic, and it's so valuable. What are the implications of early screening? I know that screening is a word we use a lot in breast cancer and colorectal cancer, but it's not been in the terminology of the myeloma world. Talk to us a little bit about that.
Yeah, absolutely. And you're right. Cancer screening saves lives. We know that if you can detect cancer early, this is when you can potentially cure it. And the idea that we should wait for people to fall apart, to have all of the cancer cells and all of the immune system dysregulated, and then we treat them, that's probably where they are metastatic already and it's too late to treat it. So early detection and early interception for all cancers in general makes a difference. Now, how can you detect it early? And you can think of screening for those people. So if you think about it, if we can detect that monoclonal protein, that MGUS early in the high risk population, we don't have to screen the whole population, because as you said, it's about 5% of the people over the age of 40 or 50. But if I can detect people who are either of African descent, Black Americans here in the United States, or if we can detect it in people who have a family history of blood cancer, although we don't know very well which mutations can make us at risk of developing that. But if we know that I have a sister or a brother or a father with myeloma or leukemia or lymphoma, I am at a higher risk of developing MGUS. Those are the people that you want to screen for. And indeed, this is what we did with a study called the PROMISE study. We started screening over 3 years ago, and we just published our data of 7,600 people where we looked for it in those high-risk populations. And we found that indeed you have it in almost 30% of people over the age of 50. That's a huge number of people having monoclonal gammopathies that are true and may indeed go on to myeloma or to lymphomas or to other things. So the numbers are much higher than what we expected. And this is because, again, it's a high-risk population. And if we use the old traditional way of serum protein electrophoresis, you would find it in 6% of those people. So it's double what we would expect in the general population. And that alone can help us say people at risk, African-American or family history of blood cancer, let's consider thinking of screening for them, because the positive value of knowing early and preventing myeloma can make a huge difference. And I would say that the blood sample is much easier than going through colonoscopy or mammography. So why wouldn't we want to make screening something that we have available for everyone and detecting it for everyone?
Wow, you make a pretty impressive case, Irene. I can't deny that. Let's unpack a couple of things you said there. And of course, it was a privilege to be a part of the PROMISE study to a certain degree with you. For our audience, can you define clearly, how did you define family history of hematologic malignancy, and what was the age cutoff for the PROMISE study, to be clear?
Yeah, so we started the PROMISE study with age 40 and above. specifically for that reason that we've seen in prior studies that age 40 and above can increase your chances of monoclonal gammopathies. And we define the family history as a first-degree relative of someone who has a blood cancer. Originally, we had it someone who has myeloma or a plasma cell disorder, and we noticed that the recent studies have shown that having a blood cancer relative, whether leukemia or lymphoma, as a first degree can also increase your risk of monoclonal gammopathies. So we changed the study to allow having a first degree relative of a CLL, lymphoma, leukemia, myeloma, and others. And indeed, we are finding that this is relatively high risk for developing monoclonal gammopathy.
So indeed, it was only just one family member that had that, not more than one.
If you have multiple family members, we just changed the study now to allow screening all of your family members, first or second degree relatives, and even going down all the way to age 18 to see what is the risk.
Excellent. Very, very helpful. And then the other point out of what you mentioned that I want to clarify for everyone, which I think was really important. Obviously, you did a lot of advanced testing, but the serum protein electrophoresis has been the historical, if I can even put it in quotations, screening test. You know, we used to give these talks and still do to primary care physicians. You know, when do you order an SPEP? When do you order this when you think unexplained anemia, unexplained renal insufficiency, suspicious bone lesions, whatever it may be, or bone pain that draws someone in? I know you did a lot of advanced testing, but talk to us just very briefly for a moment about how you went beyond just the serum protein electrophoresis to include light chain testing, which we think is standard, but even doing mass spectrometry.
Right. And I have to say that I give you all the credit, because when we designed the PROMISE study 3 years ago, you said, why don't we do mass spectrometry instead of just doing serum protein electrophoresis? And indeed we did. And because of your insight into that, it made a huge difference of understanding those very early monoclonal gammopathies, which we term now as MGIP, monoclonal gammopathy of indeterminate potential, which are very early monoclonal proteins that may in the future lead to MGUS or smoldering myeloma or others, but are also associated with increased cardiovascular risk, increased autoimmune diseases, association with other hematological malignancies. So it's opening the door for us to understand in an earlier event of immune dysregulation in many of us, what happens and why are we developing those earlier? And it's opening the door again for so many epidemiological studies in the future. Now, mass spectrometry is a much more sensitive way of looking at basically the monoclonal protein. And if you think about it, SPEP or serum protein electrophoresis is a technology that was developed 50 years ago. And hopefully we are doing much better than that. And mass spec hopefully will be the future, not only for detecting early monoclonal gammopathies, but hopefully even replacing the way that we use serum protein electrophoresis, because it's also not very accurate in the development of our prediction of response, resistance, MRD, but also in some cases like the IgA monoclonal proteins or the IgM monoclonal proteins may not be very accurate in SPEPs.
That's really, really helpful. And I think a little bit prophetic of the future. I really do see a day where we're going to abandon SPEPs and light chains and just go straight to mass spec. So before we move on to risk stratification, one point here, because in fact, I did a press interview recently, and one of the people said that they had interviewed another prominent hematologist in the myeloma world who is a little bit suspicious of this MGIP idea and said, oh, we may be over calling it. You know, that's always a risk of screening, isn't it? You don't want to have, if, for example, in colon cancer, you don't want to have all sorts of people with tiny little benign findings that may never lead to colon cancer to be over investigated, or benign changes in mammograms. What is your response to someone who says, oh, if you dig too deep and Irene looks too carefully, they're finding these tiny little things that may never be an issue? How do you respond to that?
Yeah, again, I think science is what leads us instead of us having our opinions, and science matters a lot. I think probably Bob Kyle, when he decided to think of MGUS, a lot of people told him it doesn't matter either, and it is benign until we understand it better. And whether it is MGIP or MGUS, most people will never develop myeloma, and that's the good news. The question is why, and how can we make the other people who will develop myeloma become like them, become like MGUS? So a couple of things. Yes, we are detecting very early monoclonal proteins. They're real. These are not polyclonal. They are true monoclonal proteins at a much more sensitive level compared to another test that is less sensitive. what is the implication? If truly there is a strong association with other things like cardiovascular disease, inflammation, autoimmune diseases, then we should know about it, because it's about your whole health and not just about developing cancer. If I can prevent your next heart attack, or if I can prevent, this could be a biomarker of your autoimmune diseases, then why not discover that and understand it better and let the science lead us rather than us telling ourselves what to do with it. And yes, most of the people will not develop cancer, but if we can prevent cancer, and if we can understand better biologically who will develop it and why are they developing it, then we can develop the therapy to prevent it. So I think we do need to allow science to tell us what to do with it and not add to it our own understanding of things.
I completely agree with you, Irene. You had me at MGIP. I completely agree with you. I think this has been corroborated by the massive iStop-MM study, where literally over 80,000 samples collected throughout Iceland. Now, obviously, not the same risk stratification that we're going to come to in a moment, because there really aren't very, very rare individuals of African descent in Iceland. But they demonstrated a similar concept that even in those MGUS patients that never developed myeloma, their outcomes were inferior. It speaks of something else going on, whether it's in the immune system or the whole health is the phrase you used, which I really like. And so I commend you on wanting to capture this a bit earlier. So let's think for a moment a bit about risk stratification, right? We do this in all screening, right? We don't screen every female in the world, right? We wait until people reach a certain age for breast cancer. For colon cancer, we don't do a colonoscopy on everybody. We wait till a certain age, but like myself with a positive family history, I had to start my colonoscopies earlier. Help us understand this risk stratification for screening and how it is in your mind. I know that we don't have formal recommendations yet to screen on a large scale, but if we were to go in that direction, my gut feeling is that we would start with those at highest risk. And it looks like you identified in the PROMISE study those two particularly high-risk phenomena of being of African descent and having a family history of hematologic malignancies. But tell me more about your thinking in that risk stratification process.
Yeah, and you can think of risk stratification for screening, but also risk stratification of when I diagnose a case of MGUS or even smoldering myeloma, what do I tell this patient? And that's important because we have said already not every patient will develop cancer. So you want to understand, is this MGUS more of a benign one, more of a normal phenotype? You have developed a clone that has expanded, but has not developed all of the factors, all of the hallmarks of cancer that will go on to develop myeloma. And in that case, you may feel more comfortable watching carefully. And in another person with the same tumor burden, with the same cancer cell number and M spike, they may be already developing this malignant phenotype and they're going towards myeloma. And these are the ones, like you said, running towards the cliff, and let's try to make sure we prevent it and intercept it early. And if I have two cases of MGUS or smoldering myeloma looking the same, I want to risk stratify them better by looking at multiple other factors so that I can give them in a more precise way where is their own risk of developing cancer and how can I then also precisely intercept it. Going back to screening, right now we're using very crude things like, are you of African descent? Are you, someone who has a family history? In the future, we may improve on this because ancestry is such an important thing. And we want to get off this idea of if my skin color is brown or black or white, then I am at a certain risk. I want to understand more my own ancestry and whether that can improve my risk. And as we are all starting to see germline sequencing here and there and 23andMe, the new generation of people really want to know a lot more about their own risks and understanding their own inheritance and their own ancestry more than anyone else. So I think it will come to a point where whether you are black or white or brown, if you have certain ancestral genes that predict or can predispose you to developing cancer, you may want to know about those and understand it better rather than using our skin color.
That's extremely helpful, extremely, especially you and I come from the same ancestry. So I want to learn from you as we go through. So what I'm hearing from you also, it's not just the presence or the absence or even the size of the MGUS, there are different MGUSs in terms of those that have a more benign clone versus a malignant phenotype. This is extremely insightful. But before we wrap up, Irene, I do want to ask you maybe the biggest important question of this, going back to my analogy of running towards a cliff. And I hope that if you see me running towards a cliff, you're going to pull me away before I fall over. And one of the greatest questions we struggle with in myeloma right now is, it's one thing to prognosticate around this, but when do you treat? Do you see us moving? If I use the analogy again of running, we used to say you don't have myeloma until you fall off the cliff. Well, when we changed the CRAB criteria to slim CRAB criteria, 7 years ago, almost 8 years ago now, we drew a line, let's say 50 feet short of the cliff, and said, if you cross this line, you're so close to the cliff. Yes, there's some people that may cliff run, but most people are going to fall off. Do you see us moving that line even further away from the cliff, closer to the city, as it were, in the tools and the testing that you've been demonstrating?
Yeah, two things. I think we are using now markers like the 2220, which is wonderful to tell us who's that close to the cliff, and we need to improve on it. As you can think of it, it's more like a one picture, and we want the whole video. We want to see the whole thing happening. So dynamic assessment of people as they progress, taking it into the genomics, taking it into the immune, being more precise in our prediction of who will develop myeloma can be very helpful, because you don't want to over-treat and you don't want to under-treat people. Then the second thing is, how do you intervene? Because if you use drugs that are so-so, then you don't expect to have an amazing response and potential cure. So you want to also be precise in your interception, and certain people may require 3 drugs, 4 drugs, what we use for myeloma. Certain patients may require only lenalidomide and dexamethasone, and some people may require more immune therapy, more interesting things about modulating your immune system and harnessing it, like bispecific antibodies, CAR T, and other things to truly get to that cure in smoldering myeloma. So there is a potential for developing multiple things. Think of 11-14 translocation. Wouldn't it be nice to bring in venetoclax early on? Think of someone who has a 17p deletion. You may not want to treat that patient with Lendex alone. So there are so many things of us being more precise in our interception, rather than saying everyone will get the same treatment.
Well, that was a beautiful summary and a take-home message that you've left with the crowd. I'll reword it and say it really is multiple myeloma, because there are multiple diseases in one here, from the level of MGUS to the level of smoldering to the level of active myeloma. And a one-size-fits-all is clearly not going to be the way we're going to be treating this disease in the short term and the long term. So thank you so much, Irene, for your brilliance, for your insight, for your dedication to this topic. We've learned so much today, but for our listeners, I would try and summarize it this way and say that we are coming to recognize, in general in cancer, we want to catch it early. And we now have insights into how we may be able to do so in multiple myeloma, especially in particular high-risk populations with certain ancestries and certain family histories, but also better techniques to detect it, so that we not only detect it, then we can learn appropriately then how to intervene. Can we just wait and watch longer? Should we intervene aggressively, less aggressively? And it's a beautiful description of what really precision medicine is meant to be, that we don't just treat every patient the same way. As I always say, I don't treat myeloma, I treat people. And this kind of work that Dr. Ghobrial and her team are doing clearly emphasizes that. So thank you so much for your time and your passion and your energy, Irene. It's always a pleasure to hear from you, and we trust that this will be beneficial for those who have listened today.
Thank you, Joe.
Thanks for listening to Medscape's In Discussion Multiple Myeloma podcast series with our host, Dr. Joseph Mikhael. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on multiple myeloma.